This is Brooke Hensley, and today I'm going to discuss an interesting case of a pericardial abscess. This patient presented to the emergency department with the chief complaint of shortness of breath and fever. The patient was in their 50s and 60s and was complaining of multiple things, myalgias, diarrhea, but primarily shortness of breath and fever. This was the patient's chest x-ray, which was largely unremarkable. O2 sat was 100%, normotensive, and maybe a little tachycardic to 105, but otherwise not that unremarkable. We did a bedside echo. This is the parasternal long view, which shows the LA, LV, aortic outflow tract, and the RV. This is the descending thoracic aorta, and you can see an anechoic fluid collection anterior to this, which is suggestive of a pericardial effusion. If this were a left-sided pleural effusion, you would see an anechoic fluid collection that would be abutting up against the descending thoracic aorta and layering posterior to this. This next view is a parasternal short view. You see the left ventricle here with the septum and the right ventricle. What's remarkable about this image is not only do you see this circumferential pericardial effusion, but you see deformation of the left ventricle and the right ventricle with septal bowing. You also see the shadowing here, which is actually not a rib because the shadowing begins right here in this small area of hyperechoic density, shadowing down, which is actually concerning for air. This is the apical four-chamber view with the LA, LV, RA, and RV. You see the circumferential pericardial effusion, but what's remarkable about this view is that you see diastolic collapse of the right side of the heart as well as the left side of the heart, which is concerning for evidence of cardiac tamponade. This is the subxiphoid view, where you also see diastolic collapse of the right side of the heart as well as the left side. And you see this very large circumferential pericardial effusion with echoes within it, which is concerning for debris within there. Is it an abscess? Are there fibrinous strands in there? But you have to pay attention to these echoes here. This is the CT scan of the patient's chest, and here you see the heart, and it's surrounded by this pericardial effusion that's denser than normal fluid that you would expect. You also see this little air pocket here, which is what we were seeing, that dirty shadowing on the parasternal short view. This is a series from JAMA's Rational Clinical Exam, which tries to ask the question, if your patient has cardiac tamponade, if you find that they have a pericardial effusion. And here are the various physical exam findings and their corresponding sensitivities. The physical exam findings down here in red are a Beck's triad, which is elevated JVP, decreased or muffled heart sounds, and hypotension. As you can see, the sensitivity of these three things, of the quote classic triad, are not very good. So if you're just going by hypotension and elevated JVP or any of these things, your sensitivity is not that great. But your ultrasound will certainly help you. Well, the cardiologists were also concerned that this patient was having tamponade, even though their vital signs were pretty normal. He went to the cath lab for a pericardiocentesis where they drained 330 cc's of chylous fluid. They were unable to completely drain it, so he went to the OR the next day for a median sternotomy, and he had a complete pericardiectomy and drainage of the loculated pericardial abscess and effusion. They cultured the pericardial fluid, which grew out Staph aureus. The take-home points of this teaching case are to make sure to ultrasound every patient with shortness of breath. In this case, the chest x-ray was really not helpful, and his oxygen saturation was actually 100%. Beck's triad of muffled heart sounds, increased JVP, and hypotension are really not that helpful, but your ultrasound findings are much more sensitive and specific. Number one, of course, you have to have a pericardial effusion, and number two, the right side of the heart will have diastolic collapse. The right atrium diastolic collapse has 100% sensitivity and 82% specificity. But if you have diastolic collapse of both the RA and the RV, it's actually 98% specific. Although not shown here in this case, the IVC is usually plethoric. It's 92% sensitive, but of course is not specific. But these three findings on ultrasound will help you make the diagnosis.